Thank you to everyone for attending, those who it's noon for, and those in the West Coast, the Midwest, and anywhere else. Thank you for taking the time to join us today for an exciting webinar around new opportunities for AIDS service organizations and other HIV providers to participate in Medicaid. AIDS United is committed to promoting best practices and innovative models of care, treatment, and advocacy. The Informing the Field webinars range in topics from harm reduction advocacy, access to care, healthcare reform, and retention in care, and are led by expert, cutting-edge practitioners around the country. Our presenters are each experts in their respective fields, and you'll hear from our presenter, Julia Hidalgo, today in just a moment. Today's webinar is part of our Sector Transformation Series, and in keeping with our tradition of supporting community-based organizations to think strategically about the future of their organizations, AIDS United has dedicated a small pool of resources to help you decide whether to merge, go, or grow your organization responsibly. If you are interested in any of these opportunities, make sure to contact me, Stephanie Cruz, at the email listed on the slide, scruz@aidsunited.org. And a couple of housekeeping notes for the webinar. All attendees are in listen-only mode, and anyone can ask a question at any time using the question chat feature, which is on this slide. That's what you'll see on your screen. You can use this chat feature to communicate with the group as well as raise your hand or speak to someone in particular on the webinar. If anyone is experiencing technical difficulties at any point, please contact Kelly Stevens at kstevens@aidsunited.org, or you can call 202-408-4848, extension 202. And then lastly, there will be a recording and slides of the presentation available after this webinar. Today, we'd like to thank Johnson & Johnson, whose support of the Sector Transformation Initiative at AIDS United is supporting this webinar in particular, and thanks to our contributor, Dr. Hidalgo, who will be presenting for the entire hour and a half of this webinar. And lastly, we just want to acknowledge all of the direct service providers and people living with AIDS from whom we continue to learn so much from and who have contributed in some way to this presentation. And so with that, I will pass the presenter role to Julia, who will begin in just a moment.
I just lost the slide. Oops. I just lost the slides.
Okay, just one moment.
Okay. Well, to keep you entertained while I'm waiting to see my slides, this is Julia Hidalgo. I'm so happy that you were able to join us for lunch or breakfast in your respective offices. I see from the registration that many of you are old friends and colleagues, and I appreciate that you took some time out on your really busy day during this busy season to get together with us to discuss what I think is a really exciting time in HIV care, also fraught with some anxiety and some worry. Just by way of quick background, excuse me, I have worked in HIV and HIV finance for about 30 years. I've spent a pretty long period of time in that role working with Medicaid and commercial insurance and TRICARE insurance systems on a variety of different fronts, including the design of new and finance of new payment systems and to organize those systems to ensure access to HIV care. And so we are, as many of you know, painfully perhaps, entering a new era in HIV services financing, and it's important that all of us try to the best of our ability and the amount of time that we have available in our day to really get up to speed about what the new opportunities are and make sure that your organizations and your clients and patients are able to benefit from them. So today we're going to talk about, I hope, an exciting topic related to the new opportunities through federal and state Medicaid programs to arrange for and provide preventive services and to actually make sure that your organizations are paid for to render those services. So today, real quickly, we're going to be talking about the Centers for Medicare and Medicaid Services Preventive Services Policy. We're going to review some of the basics about Medicaid, just so everyone's on an even playing field related to the program. And we're going to talk specifically about what CMS requires at the federal level for states to create reimbursable HIV primary and secondary prevention services that can be integrated into Medicaid fee-for-service and managed care preventive service systems. We're also going to talk, and I hope energize you to think about how your organizations can help participate in the design of new Medicaid preventive services that will purchase services in a different way for a large and new set of workforce. In some of your states, I see those activities have already been underway for quite a while, but in many states, they are just beginning. And we're going to talk about how you can partner with other advocates in other disease-specific communities, professional associations, and your state Medicaid program to build out preventive services and make sure that your workers and your organizations can participate actively and be paid. We're also going to talk about ways to collaborate with clinicians, health departments, and other healthcare providers, as well as with Medicaid managed care organizations to offer reimbursable HIV preventive services. And I just once again want to make sure that folks are aware that in many of your communities, the boat is still being built. It's at the dock. You have an opportunity to help pick out sort of the features of these systems and to contribute to ensure that HIV infected folks' needs and service requirements are reflected in those new systems. Next slide, please. So just a real quick refresher. I think many folks assume that they know what Medicaid is, and I'm hoping that at this point in your careers you do too, but just a quick refresher. Medicaid is a federal and state partnership, and it's a somewhat disequal partnership in that the federal government gets to create and enforce lots of rules that states willingly accept because the federal program actually contributes the lion's share of finance in most states. Those programs vary considerably in terms of how much states contribute to the Medicaid program, and that's based on those states' population's per capita income. So as you can see here, the federal medical assistance percentage, or the FMAP, varies pretty widely depending on the income of the state jurisdiction. States have considerable flexibility in reform. However, they do need to adhere to the federal statute and to regulations set forth by the Medicaid program at CMS. The state's Medicaid plans really are the architecture in a written form for the program and really specify the approach that Medicaid takes to address the federal mandatory statutory requirements. There are optional services beyond the mandatory services that must be required. States can pick and choose among those optional services. And as we all know, because of the Supreme Court ruling, states also get to voluntarily determine if they will expand eligibility. Next slide, please. Now, the bottom line for the federal requirements, so there are very specific requirements that have to have in their plan. The amount of services, duration, the scopes of what are called benefits, or in Ryan White world we would call service categories, have to be sufficient to achieve the purpose of the service. The Medicaid programs cannot discriminate or have variable available services based on a beneficiary or a member, which is what we call folks in Medicaid, or enrollee, based on their diagnosis. Within the state Medicaid program, there has to be comparability, statewide coverage, and inclusion of what's called willing and qualified providers. Now, some of this language is a little odd, and that's specifically odd language that comes from CMS. Also, beneficiaries must have freedom of choice of qualified providers, including managed care organizations in states with managed care payment and delivery systems. Now, the state plans also lay out not only how Medicaid will pay for things, but also how they will be delivering services. And that's really important because that's a critical role that Medicaid programs need to undertake. And they need to think very carefully about how they will deliver services to all eligible and enrolled individuals, regardless of where they live or their personal circumstances and travel time and so on. Now, for those of you who are interested, your state's Medicaid plan and then subsequent state plan amendments that I'll talk about in a second are on the CMS Medicaid website. Now, I've put the URLs in the presentation, so you have those available to you. We'll make sure that you have a live version of the slides so that you can actually click on the URLs and instantaneously be brought to the right websites. Next, please. Now, in terms of preventive services, it's really important to understand sort of what Medicaid expects and requires at the federal level that states do. The CMS State Medicaid Manual, which I'm certainly sure some of you may want to read in your wakeless hours, really specifies the preventive services that are fundable and payable by a state Medicaid program. Those services have to involve direct patient care, and I'll get to sort of what that means in a second. They have to be expressly related to diagnosis or treating or preventing illness, injury, or other impairments, and must be related specifically to beneficiaries' physical or mental health. And they can be provided either through the fee-for-service Medicaid program or managed care organizations. It's important to recognize, however, that non-medical preventive services, for which I'm sure we could think of lots of things, sort of generalized population campaigns around stopping smoking, improving the water quality in the community, are not allowed if they involve broader social or environmental issues, and these are not covered services. Next, please. Now, Medicaid pays at the state level for preventive services in a variety of different ways. It's very important to understand that preventive services have been an important, critical component of Medicaid covered benefits throughout the history of the program. So the preventive services we're talking about today in the broader scheme of things are nothing new. What's really important, though, is that we're really trying to maximize those models for services provided to not only HIV seropositive folks, but others as well. So payment and delivery can be achieved through several manners, through what's called a SPA or state plan amendment, through waivers and demonstrations, and I'll explain that in a minute, through managed care organization contracting, And then most recently through innovation grants through the Center for Medicare and Medicaid Innovation, which is referred to as the Innovation Center, that is funding new state Medicaid program delivery and payment models. Funds are being awarded to state Medicaid programs directly. And then also community providers of a variety of sorts can also, on a rolling grant application basis, submit their great ideas for innovation in terms of both delivery of service as well as financing. Now, the Innovation Center has just completed their most recent round of awards, so stay tuned for new activities. This, having just been through this application process, this is not your usual Ryan White or CDC application process. It requires extremely intricate financing analysis and really close partnership with your Medicaid programs. But stay tuned. If you have great ideas, I would check with CMS to see what their new ideas or their new cycle will be coming up. And it will really literally take 9 to 12 months to really build out your application. So you may, if you think you have a great idea or if you want to reapply, you need to get started actually reasonably soon. Next, please. Now, as I mentioned, state plan amendments are important because state Medicaid programs cannot summarily determine that they want to change the design of their program without CMS approval. So they have to submit what are called SPAs to CMS for review and approval. If they want to make changes in Medicaid eligibility, the coverage of services that they want to provide, or reimbursement or payment for those services. CMS has a process by which they review those SPAs before they determine whether or not it should go forward. And then they often will work with the state Medicaid program in an iterative way to make sure that the amendment really meets the requirements of the federal program, as well as really realistically meeting the needs of individuals that are covered in that jurisdiction. Now, it's important to note that there are lots of SPAs currently being reviewed, and those are posted on the CMS website. If you are interested in what may be going on in the planning stage in your state, it's really important to look at those SPAs, to talk to your colleagues in the HIV and other advocacy communities, particularly if you see that there are activities that are of concern to you or things that really, in fact, could benefit your programs and your clients so that you get ready for once those SPAs are actually approved by the feds. Next, please. Now, I want to also talk about waivers and demonstrations, which are another way that preventive services can be funded. And I'm not going to go into this slide in great detail, but it's important to understand that even with the Affordable Care Act as it now stands, we continue to be able to design, even in the states where Medicaid expansion has not moved forward, waivers and demonstrations have been used by some of those states, and I could name a few, but we'll keep it a big secret, where the Medicaid program staff really want to re-engineer and do the right thing by Medicaid beneficiaries, but they're not really able under the current political environment to expand eligibility. So we're seeing in the non-expansion states really innovative and important activities. And I'll highlight two, for example. In Florida, a non-expansion state, they have an AIDS and HIV capitated reimbursement system and also offer a very expansive mental health benefit that is extraordinarily generous and really, really well thought out. In Texas, another non-expansion state, they've also similarly built out in their waiver program really innovative activities, including covering things like linkage to care activities by local health departments for HIV-infected beneficiaries. So it's important to be aware of those waiver demonstrations and to work with your state if they are interested and willing to consider alternative approaches through a waiver and demonstration activity. And the CMS website here offers by state what those programs are currently, as well as the waiver and demonstration applications that have been filed. Next, please. Now here I'm going to give you a couple of real examples of preventive services that have been integrated by state Medicaid programs into their managed care organization contracts that really specifically relate to HIV preventive services. As you can see here, in Texas, managed care organizations have to provide both STD and HIV prevention services, counseling, testing, and treatment, and really a sort of generous and very targeted set of preventive services that are required for organizations participating in Medicaid. Next, please. Similarly, in New Jersey, the managed care contracts are very specific around preventive services. And I offer these to you because if in your managed care model contracts, which are usually posted on your Medicaid program's website, you do not see this sort of important preventive service being incorporated in the managed care contract language, the advocacy community really needs to step up and to communicate with them that other states have in their contracts this sort of language. Here we can see in New Jersey some very specific language related to HIV prevention for pregnant women. And then on the next slide, similar language that goes beyond both women and pregnancy to a generalized set of preventive activities that are required to be offered by managed care contractors to Medicaid beneficiaries there in New Jersey. Once again, these are examples of language that we want to see in the contracts. That's step one. Step two, you all need to be in these jurisdictions aware that that language exists, because this is your marketing opportunity to managed care plans to help them to actually provide these services, because you already know how to do it and you have the workforce available. Next, please. Now, in terms of other new opportunities, and I'm hoping you're already excited about what may already exist in your state through the Waiver and Demonstration and Innovation Center, but with the CMS new ruling related to preventive services, we have yet another opportunity to really be creative with preventive services for both HIV as well as for populations with a wide array of other preventive services needs. In July, CMS published a final rule on January of, and I don't do very well math today, I guess, in January of 2014. You don't have to wait until the next century. And before the rule, preventive services could only be provided by a physician or other licensed practitioner, or what's called an OLP, of the healing arts to be paid by Medicaid. This is not my language, obviously. This is Medicaid language. After the rule, other practitioners, just not physicians, and other licensed practitioners can be paid to provide preventive services recommended by a physician. Now, it's important to understand what this means, because we've had a lot of discussions around how we might, for example, be able to maximize reimbursement for rapid testing out in the community through this new rule. Well, the fact is that regardless of who is going to provide the preventive service, it must be recommended by a physician or other licensed practitioner. So in other words, it cannot be just an oral recommendation of a physician in the hall as a case manager being told that all the patients on Medicaid in the clinic should have HIV testing. It has to be recommended related to specific patients within the practice, and that has to be documented in the health record. It can't just be something that's sort of a standing order, for example, that's delivered orally. Next. Now, additionally, the ruling assigns authority to implement this new opportunity to the state Medicaid programs. The expectation that CMS has laid out in the final rule is in order for a state Medicaid program to implement these new activities, they need to develop the preventive services program that will be operated through this new paradigm. So CMS expects a state to define what are called practitioner qualifications, including the education, training, credentialing, or registration of those individuals. They need to ensure appropriate services are provided by those practitioners. They need to specify exactly which preventive services need to be provided. Now, preventive services are coded pretty generally in CPT codes, for example, so we don't need to go way in the weeds on the definitions, but they do need to be consistent with the CMS Medicaid manual. And then states are also required to design the reimbursement methods by which they're going to pay for those services and how they're going to pay either individually as freestanding workers or pay for providers as organizations. Medicaid programs are allowed to offer preventive services on a voluntary basis. This is not a requirement of the states. They do not have to build out these new systems, but CMS is strongly encouraging them. And through community advocacy, we need to make sure that the state programs really do understand the need to be able to expand preventive services through this new staffing model. And then states also can increase access to preventive services to beneficiaries that are not currently being offered those services. The ruling, however, and I think it's really important to understand this, the ruling does not define a specific type of personnel to be covered. And what we see now across the country is sort of a jump in logic among advocates that this means community health workers are the type of personnel that the ruling is speaking to. That's actually not specified in the ruling. So there are a variety, an array of both licensed and non-licensed, non-accredited individuals that could render these services, but it is not exclusively community health workers. Next, please. Now, the ACA offers even more opportunities that we need to think about. For states that are expanding Medicaid eligibility, they have to cover without a cost share by the client, the beneficiary, for all preventive services that are recommended with an A or B grade by the U.S. Preventive Services Task Force. And this is a component of the ACA. Voluntarily, states can also expand in those expansion states to cover individuals that are already enrolled in the program to ensure that they also can have expanded benefits. And then for states that are not expanding Medicaid eligibility to additional populations, they can also voluntarily cover preventive services that are graded A or B by the task force. Next, please. So what Medicaid programs need to do in order to implement this activity is they need to design one of these SPAs that we discussed earlier to cover preventive services. So as you can see here, as I mentioned, there are really three sets of activities that they need to build out in order to design their state plan amendment. And this is where the opportunities start to really unfold for advocacy and collaboration with the states. Now, in the SPA, the Medicaid program requirements, as you can see here, the sort of standard requirements have to be in place. But within that, then they can design the program to meet the needs of clients and enrollees with a great deal of creativity. CMS is very happy to provide technical assistance to states to help them to design their spas. And they also are developing a prevention learning network for state Medicaid programs so that all can learn from each other. And as I said earlier, some states are well ahead of others in already having designed and implemented these programs for many years. And I'll point, for example, to New Mexico and Texas that have very expansive preventive service programs that are really based on community health worker type personnel, but are also doing things like paying for disease investigation specialists in health departments and other activities. So if you or your Medicaid program have questions, CMS has a little mailbox all set up, ready to accept their questions. Next. Now, it's really important, now that I've sort of helped you, hopefully, to lay the foundation to get moving in your local jurisdictions, and we're hoping to hear from folks in a few minutes, a couple of you that are already perhaps very engaged in building these new systems with your Medicaid partners. But it's really important to get going and to understand what's going on in your local jurisdiction. So a couple of things that you can do. Very important to look, before you approach your Medicaid program with some bright idea, to look at what they're already doing or what they already have in place. So getting up to speed on your Medicaid state plan, spas, and waivers in your state are important. Do all of you need to do this with your precious and spare time? No. If you have HIV advocates who are working with you, policy type folks, this is a great job for them to do. Also, the American Public Health Association has a community health worker section with lots of resources to give you ideas about what you could be doing in your communities, and also has information about what is already going on in quite a few states across the country. Also, the Association of State and Territorial Health Officials is keeping track of what's going on in building out state community health worker activities, and here is the URL for that website as well. Next. Now, a couple of other things to know. CMS is very dedicated and very interested in promoting HIV preventive services across the country. This is part of the National HIV/AIDS Strategy and is part of the HIV Care Continuum initiative from the White House. So they're very interested in making sure preventive services for folks that are either at risk or that are infected with HIV can receive both primary and secondary prevention services. So they had issued a November 2013 update to the initial final ruling that came out, and they specifically highlighted the task force recommendations for routine HIV screening for adolescents and adults as sort of a nudge to the Medicaid programs at the state level to get going in terms of covering those services. And they also are really encouraging and promoting new opportunities for emerging new types of personnel that I've identified here, or perhaps paying for personnel that you already employ. And then also new opportunities are specified related to specific types of services. Next, please. Now, I'm going to give you some examples, and these are just examples of how we can get creative in terms of the delivery and design of HIV preventive services. HIV screening, as we all know, needs to be expanded greatly among folks that are enrolled in Medicaid. And so new opportunities for payment for pre- and post-test counseling based on the referral by a provider to your counseling staff could be reimbursable under this new paradigm. Behavioral prevention services that are being provided specifically to individuals to prevent primary infection could be also considered as possible services. We now have the wonderful new opportunity for biomedical prevention services through PrEP. There, as I hope you know, not only the component of the medication itself, but the fact that there are a whole support and education set of activities that really need to go on to make sure that folks receiving Truvada really understand what they're doing, making sure that they're adherent to their medication, helping them to really support ongoing treatment and regimen adherence. These are all sorts of coaching, support, and counseling services that could be considered a preventive activity. Linkage, retention, and re-engagement services that are directly provided to individuals enrolled in Medicaid are certainly allowable under these activities because you are preventing both secondary infection among seropositives, but you're ensuring that they're actually getting the sorts of ongoing medical treatment and medication that are going to keep them healthy out of the hospital and out of the emergency room, and able to really have sort of normalized HIV medical services. Care coordination is a perfectly legitimate sort of activity that is being provided through these preventive services. Often in Medicaid language, these are considered to be either care or disease management sorts of terminology when you talk to Medicaid and to managed care organizations. But these are almost identical types of services when we look, for example, at Medicaid managed care contracts to the sorts of case management services that we provide in the Ryan White program. Home visiting, also a very important set of activities for some clients, are allowable under this new paradigm, as well as medication and med ed and support services, side effect management, discordant couples counseling, harm reduction activities. Where you have services that can be clearly defined and are evidence-based, these are the sorts of services that could be covered as discussed and organized with your state Medicaid programs. Next, please. Now, I just want to share with you some data, because one of the things in terms of coordinating and encouraging Medicaid programs to really invest in preventive services for clients that are at risk for infected for HIV, part of the issue is doing the right thing. Part of the issue is meeting the federal requirements, but also Medicaid programs are not too surprisingly heavily sort of encouraged by a pretty substantial return on their investment. For what we're suggesting, as we all can agree, in the Medicaid world are pretty inexpensive services, and by and large, because many of the workers that we're talking about are relatively inexpensive workforce. So here's an example of a recent application that we submitted to the CMS Innovation Center for a grant for the District of Columbia for Medicaid beneficiaries that was just awarded September 1st. So we're really excited about that. But one of the things that they were particularly convinced by was our ability to demonstrate that we were actually going to be saving, both in our prevention model and our care model, really substantial amounts of money for the DC Medicaid program. So we calculated based on the cost of preventive services based on real data from the District of Columbia Medicaid's program, which they share with us, their expenditure data. We anticipate in this project that we were just funded about $1 million of net savings over a 3-year period for about 23,000 folks. And this is your basic counseling and testing and HIV sort of post-test counseling and linkage activities. Where they were particularly excited was the opportunity to save them a lot of money for folks that are HIV positive. And so we estimated about a $40 million cost savings if we were able to actually get folks identified and in care and normalize their treatment over time. And so we've estimated, based on this project, about a $43 million cost savings just in the District of Columbia by providing a pretty preventive service-heavy set of services, and we're successful. And these are the actual kinds of data that really get the attention of Medicaid staff, although not the only evidence of why this is an important activity and investment that they should really undertake. Next, please. So what are your next steps in terms of getting yourselves, your organizations, the HIV advocacy community energized and ready to go to either help shape new preventive services activities or to really energize activities that are already underway and under payment already in your state Medicaid program? So it's important to understand that some folks already have a lot of these services already built out in their states. When I go out and do training, I often find, however, that HIV providers and line staff are totally unaware that these opportunities are in place. It's very common for folks not to really understand what payment options are already available to them. And I'm not just talking about HIV medical providers. I'm talking about prevention and wraparound service providers. We need to look, for those of you who have managed care programs in your Medicaid programs across the states, you need to look at those model contracts to see what's already identified in terms of preventive services. And then also, in many states, we're finding that there are already actually quite a few that have training and credentialing programs already in place. So, for example, we were just working in Alabama for Health HIV last week, and there are already training programs available in that state through one of their local colleges. You need to remember that although we all think HIV is absolutely critical and we are totally dedicated and focused on HIV, we make a better argument for preventive services if we're able to band together with other organizations and advocates and to really go and approach Medicaid programs as a group. So I encourage you to find what I think of as affinity groups in your state that have very similar interests and that are interested in collaborating with you. And so you can see here just, and this is off the top of my head, sort of the key types of advocacy groups and providers that have very common interests in making sure preventive services are being offered not only to the folks that they're focusing on, but that you're maybe very likely to be focusing on as well. Next, please. Also, it's really important to, before you get in a lather and start working together, that you reach out to your state Medicaid program and to managed care organizations participating in Medicaid to find out what they're already doing, what their interests are around preventive services and payment systems around them, to understand what their concerns and their challenges are so that you're able to really work practically in their environment. Now, this is not a light undertaking, and I've worked with Medicaid programs for well over 30 years now. It's a different culture. They have different pressure points. They have different concerns, but we also have lots of mutual interests and lots of mutual objectives that we can build on together. It is not surprising if they do not return your calls. You may not be able to identify the right person to talk to, but we're finding in many jurisdictions that there are key people that are already assigned to work on these sorts of innovative activities. It's important then to collaborate with your advocacy partners and with Medicaid programs to do a couple of things. First of all, you really need to build a service delivery system that makes sense, that you can articulate in your state plan amendment. So practical things like identifying and defining the units of service to be covered, providing evidence of the effectiveness of those services. As remember, the final ruling said that you had to have some sort of licensed provider refer the beneficiary for services, so that referral process needs to be clearly laid out, not specific to individual providers, but how just generally that flow of referral from the health practice to your organization or to your program is going to work. If there are going to be service limitations, those need to be specified. If there are specific location requirements or limits, those need to be specified as well. Next, please. Also, you need to think about how this service delivery system is going to pay you and other providers to actually offer those services. So a payment system needs to be put into place that makes the most sense for organizations such as yourselves. Now, I really strongly suggest you want to avoid fee-for-service payment. And one of the reasons why is that particularly many community-based organizations do not have the capacity to generate and submit fee-for-service claims to a Medicaid managed care plan or to a fee-for-service program. Often what you will find is that the Medicaid program perhaps may be much more interested in paying you what may feel in our finance world as a capitated arrangement, where you will be assigned X number of clients in a month and you will do Y things to those and you will be paid a flat amount per client. This is a much easier process and doesn't require you to install billing systems. Also, many managed care organizations have already undertaken with their administrative budgets these activities and contracted directly with organizations to provide preventive services. Once again, those kinds of budgets look really similar to what we're used to in grants-based budgeting and payment. Also, it may be really, really helpful if you need to make the case on what the return on investment is, and if you all have academic or other analytic type partner, what the cost effectiveness of these programs are. And I can guarantee you, if you're using sort of quasi or non-licensed personnel, you're actually going to be able to save substantial amounts of money. One of the things I've noticed in many states, an inpatient admission probably would allow you to pay for 2 or 3 community health workers to work at least 6 to 12 months because the inpatient stays are so expensive. So anything we can do to avoid those expensive costs are going to be terrific ways to underscore the return on investment in this. Also, it's going to be important as you're working with your collaborators to develop quality, performance, and outcome methods. And in the Ryan White world, we are very well aware of how to do this, hopefully, and already have quality programs embedded in your organizations. Because we want to make sure that the preventive services really fulfill their promise. It's not just enough to build a program. We really need to make sure that the services provided are high quality. Next, please. Now, I just want to point out, and this is information that's available in various different sources that I show you here below. But it's very important that you understand if you're moving into provision of preventive services and working with Medicaid for the first time, really what is going to be required of you. So you need, as you can see here, you need to make sure that contracting really is consistent with your organization's vision. Infrastructure needs to be in place to meet the contract requirements. You need to be able to, once again, define your services and target populations that you're going to provide services to. You need to make very carefully an effort to have your unit cost analysis done, sure that you're getting paid enough to cover your costs. And I can't underscore this enough. You need to make sure that this is a financially sustainable relationship. And you need to make sure that however you're going to get paid is clear to you and that you're not going to be assuming a lot of financial risk. and that payment is very simple, straightforward, and doesn't become a huge burden. Now, I do want to point out for those of you who are Ryan White program providers that we do need to be careful to recognize that this is not money that you're going to be piling on top of your Ryan White program's revenue for the same services, because under the payer of last resort policy, you need to offset your Ryan White budget with these new program incomes. You also need to make sure that you are working to develop your marketing strategy for not only participating in Medicaid and with Medicaid managed care organizations, but also to attract and provide services to beneficiaries. Now, before you sign those contracts, you need to make sure you have a legal counsel that can advise you about terms and conditions. There are going to be a lot of boilerplate in some of these contracts. So if you're not sure if you're ready, there are a couple of resources I want to point out. The HIV Medicine Association has a contracting guide for medical providers, and Health HIV will have a similar guide for HIV prevention and wraparound service providers over really the next month or so. It's already built out. They're just getting it ready for publication. And those will help guide you specifically on contracting. Next, please. Now, I want to generate some conversation. I see that there are almost 100 folks out there listening, at least, if not 2 or 3, sitting in your office eating sandwiches together. So we asked earlier if any of you are actually in the throes of working with other community partners and your Medicaid programs. If you'd like to share the activities that you're undertaking, we'd love to hear from you. And I just offered a couple of questions just to sort of get the ball rolling in terms of what you might share with us. So the operator will open it up. Do we have any volunteers?
And I'd just like to ask that folks go ahead and use the raise hand feature, and then we'll go ahead and unmute you as we see them pop up. Thanks.
So if we don't have any volunteers, I'm going to start picking on people. Okay, seeing none, do we have any folks from Texas, New Mexico, Minnesota?
Hi, we have Megan Hannon who's raised her hand.
I'm hearing lots of
There's a
static. Do we have anybody on the line?
Hi, sorry. Can you hear me, Megan Hannon?
Yep, Megan Hannon, you can go ahead.
Oh, okay. Sorry, I think I hit that by mistake. But I did write in a question. So we do testing and Ryan White programs here in Maine. And I was hoping, and in fact, our latest prevention grant requires us to bill Medicaid when somebody has Medicaid. However, given what you've just said, needing an actual referral from a primary care provider or someone, what is anybody's, how would that benefit the primary care person to refer them to us when they could just do the test right there themselves and get paid for it?
You mean the HIV test specifically?
Yeah, or any other STI test for that matter.
Well, I would suggest a couple of things, and we're getting some feedback off of your phone, so if you could just mute it for a quick second. A couple of things. First of all, many providers and folks in Maine may be different, but many HIV clinicians or clinicians that are offering HIV testing or that could be offering testing indicate that they really don't want to because they don't want to give the test results if they're positive. And so this is an opportunity, for example, to partner with a clinician to actually provide the positive test results to a patient in the practice while they're there in the office, and then to offer linkage to care and sort of red carpet service to get them into treatment. And often we find that community-based providers do not want to engage in HIV testing because they don't want to tell the test result, and they have absolutely no idea what to do next with the patient. All they know is they don't know HIV, and they don't want somebody crying in their office and having all sorts of emotional stuff going on. So that might be something that you could incorporate in your marketing strategy with providers. Okay, other questions? And certainly feel free to type them into the chat box if you're feeling particularly shy today.
Julia, I do have some questions from the audience, but I didn't know if you wanted to try to get any more engagement for this slide, the questions that you threw out to anyone.
Okay, here, we're going to give folks one more chance, and then we'll move to the questions. Anybody have any specific activities that you're engaged in that you'd like to share with us?
And Julia, we have a request to reiterate some of the points that you had just made.
Oh, specifically around HIV testing?
Mm-hmm.
Okay. Well, once again, I think we're all pretty aware that at least some of the excuse or some of the reasons why both clinicians in private practice, folks in outpatient departments, as well as in emergency rooms, for example, give is that they really don't feel comfortable beyond giving, writing the order for the HIV test or doing the rapid test themselves. Often the rationale for not testing is that they don't feel comfortable providing an HIV positive test result because of the emotional response that they would anticipate, but also because they may not be really aware of the post-test counseling activities that really need to go on, issues related to harm reduction, making sure that the sexual partners of the individual are protected as well, and then just knowing where to refer folks if they don't feel comfortable providing ongoing HIV treatment. And so, I'm suggesting that there may be opportunities to reach out to community providers, and we know who some of them are because of HIV surveillance data, and reaching out to folks that are maybe thinking or might be receptive to partnering with a community-based organization, for example, or HIV clinical provider to have workers of a variety of types that are credentialed to do this sort of post-test counseling and linkage to care activities, and working together when they have a seropositive patient for which they need to give the test results. Of course, it's important that we be nimble, that we can hop in the car, and that we can help if it's a face-to-face session to work out that. But that would be one opportunity, I would say, would be clearly within the final rule, among many, many other activities.
And we have a comment from Ms. Janice Hand, who says, in Wisconsin, our ASO developed a piece of legislation very early on that essentially limits funding for case management to go only to ASOs. This has been a great barrier for anyone else wanting to get into Medicaid, except on even the smallest item.
Okay, I guess I would challenge Janice, and hi Janice, to talk about what you all are doing to remedy that situation.
Janice, I've unmuted you. Would you like to expand? Okay.
Is Janice on the line?
I'm actually on the computer.
Oh.
Can you hear me?
Okay, we can hear you.
Yes, I can.
Yep.
Okay. Well, we've basically tried to identify what we could get for funding, mostly because of the payer of last resort issue and the need for us to essentially tell the Ryan White program that, you know, there is no potential funding for what we do because, frankly, the ASO has captured all of it. And so that's been one thing that we basically were trying to do. We haven't really tried to force them to give us some of it because, you know, we're not trying to engage with them at that level. We don't want them to see us as the bad guys who go out and steal money from them or steal patients from them. And so we're not really trying to do that kind of thing. We're trying to fit where there are gaps. And when we can identify something that we could potentially get funded from Medicaid, we might actually do something that was in that area or offer that as an option for them.
And also, Janice, in Wisconsin, you all have a waiver. I believe it's in Milwaukee. Has any of that set of funding been helpful to any of the other providers besides the one set that seemed to be driving that process?
I'm not sure which waiver you're referring to. We're in a state where, you know, they didn't accept any Medicaid waiver.
It's the patient-centered medical home project.
Oh, I'm not certain of that. I'm not certain of how that's been useful.
Okay. Well, that might be something you might want to explore a little bit because
okay.
that may be, they have a state plan amendment, and that might be something you could pivot off of. It shouldn't be written just for one provider. It should be written for other HIV providers. So you may want to explore that a little bit. And I'm certainly happy to touch base with you offline.
Okay.
Operator, other questions?
We have one from Paula Peters who asks, is there any barrier to billing for these services by non-provider staff if you are an FQHC?
There's nothing that I saw in the final ruling that would address that. I think, though, you might want to explore it a little bit with your Medicaid program just before you get all excited and launch into new territory. You may want to verify that. My impression, though, is that there wouldn't be an issue because it's not sort of your standard kind of FQHC set of bundled services for which your payment structure rotates around. But I would suggest definitely talking to the state Medicaid program. I don't think, you know, and I can't speak on the behalf of CMS, obviously, but I can't imagine they would anticipate designing this whole set of innovative activities and then prohibit through existing finance structure FQHCs from actually benefiting from it, given their pivotal role.
Okay.
Other questions?
Stephanie, did you want to share some of the ones that you have?
Sure. From Kathy in Oklahoma, asked during the slide with the example of HIV preventive services, how does this information pertain to states who did not take the expansion of Medicaid? For example, Oklahoma did not take the Medicaid expansion under the ACA.
Well, as I mentioned, states that have not expanded can, and many of them have, instituted preventive services for a variety of different covered members or enrollees for many years. So what, I wouldn't assume that they're not doing anything. I would perhaps look at covered benefits as they're defined in your Medicaid program on their website and see, first of all, exactly what they will or will not provide. And we have, for other projects, looked carefully at those websites and found that there are preventive services that are, in fact, covered. And then if they're not, many states, once again, are moving definitely forward, regardless of Medicaid expansion, for a variety of preventive services. For one reason, it will ultimately save them money among the folks that they already have enrolled. And we're talking about, you know, a variety of programs that range from incredibly narrow Medicaid programs and benefits to ones that have pretty generous programs, but for political reasons, they've not been able to move forward and expand. So I would definitely, you know, really reach out. I'd also talk to some of your colleagues in other advocacy communities and other sort of population-specific providers to get their take on what could be done. I would not assume, however, that you're going to get a no. I would assume that you might be able to arrange a dialogue and get more information, particularly if you're banding together as a group.
Okay, Julia, I have another question from Rachel around the making the case to Medicaid for HIV preventive services slide. Can you share the methodology for determining ROI? This is very important for other programs. And then in parentheses, it seems like ROI would depend on both the prevalence/incidence in the population.
Right. Well, first of all, and I am hoping that you would be able to also similarly get information from the Medicaid program you're working with, as we're able to for the District of Columbia. However, it's been my experience that for a variety of reasons, Medicaid programs are sometimes unresponsive to get their aggregate expenditure data for individuals that are HIV infected, and then to get cost information in terms of what their covered services would cost, such as HIV testing. So I'm not suggesting this lightly, and I work with many sets of state folks, such as yourselves, where the Medicaid programs have said they're too busy, and they'll, you know, check in with them in a year. However, once again, you know, with the National HIV/AIDS strategy and with CMS commitment, as well as for a variety of reasons, including that there are Medicaid folks who really want to do the right thing, to ask them to generate some aggregate data for the most recent period of time available, which is usually a couple of years past, because it takes a while for all the claims to come in. And so what we did was get aggregate data for the most recent time period for the District of Columbia using a code net that they had designed. If you're not sure what the code net is and they don't understand in your Medicaid program what the code net is, please do contact me. I've been working in this area for about 30 years now. I have the code net. I'm happy to share that with you, and it's actually been used in quite a few states. They need to generate the claims files. They need to do the aggregate analysis. And then what we did was actually to not only calculate the aggregate cost, but we also calculated, based on the number of enrollees, how much per capita. And then based on what our proposed project was, we calculated how many folks we thought we would be providing preventive services to, as well as care services. So we used the aggregate data to calculate the cost. We looked at the cost centers that were most obviously highly expensive and pointed out to the Medicaid program where there were obvious areas of improvement that we would work with them on, including a lot of inpatient stays, and curiously, a lot of nursing home stays and extended care stays among non-elderly. So we already knew that there were some things that we definitely could do for those folks through our intervention activities. And then compared and calculated the expenditures that were likely to occur versus what the costs are to the proposed program as we submitted to CMS. And that's where we calculated the return on investment. And if you want more detail, because I know that many of you have your eyes glazed over and your heads tilted against your chairs taking a nap, this is not a topic for some of you. But for folks that are interested, I'm happy to share more detail and description of the calculation. It's actually fairly simple math. It's once you get the data and you have your anticipated project costs, the actual math itself is pretty straightforward.
And Julia, we have a hand up from LaDonna Byans. I'm going to open your line now. LaDonna, you can speak. LaDonna, are you on the line now?
Hi, LaDonna. Did you have a comment or a question?
Alrighty. I guess we'll move to the next question. Stephanie?
Sure, sounds good. Maybe we'll get LaDonna back at some point. The next question is from Kathy. Would current counseling and testing staff, parentheses, and treatment advocates need to become community health workers? Is that the level of credentialing we would need for line staff?
Well, this is a little bit tricky because there has been a large and long-standing sort of movement towards this workforce called community health workers. And that has not necessarily been something that in HIV community we've sort of defined our workers as. We call them all sorts of other things: peer workers, linkage workers, outreach workers, treatment advocates, you name it, we have a title for it. What we call folks is not as important as designing a credentialing program and collaborating with other advocates. So I would imagine that a state Medicaid program is not going to build out just a workforce for HIV and submit a state plan amendment around that, although depending on the community and the state, that may be something that might happen. But what is more likely to happen is that the state Medicaid program is going to build out a generalized workforce that it will include folks that do HIV services as well as asthma, diabetes, and so on, and have a generalized training and credentialing program that would be available. Now, there's lots of details around that you all can help shape. For example, and I know some jurisdictions have this, a credentialing program specifically for HIV non-licensed personnel for which they get credentialed, and we know in some places, case managers are certified, for example. In negotiating with Medicaid, perhaps those folks can be grandfathered or grandmothered into the program. Or the training that they have gone through might be used as the basis for curriculum to credential other folks. The important thing to understand in the final ruling is that the expectation is that the Medicaid program explain in their state plan amendment what the process is for credentialing, quote, licensing, giving someone a cute piece of paper at the end and a little diploma ceremony, what that process is going to be, and how does the Medicaid program know that those folks are going to know how to do their jobs. And that is where the negotiation has to take place between advocacy communities, professional associations, the Medicaid program. It could involve licensing and certification bureaus depending on what processes a state wants to pursue. They don't need to be, quote, licensed, as we know with licensure. But in some jurisdictions, the Medicaid program may want to have that as their process. If you think about it, in a state that might be licensing tattoo artists, might actually want to, quote, license folks that are doing services such as we're suggesting. So it really depends on the environment in the community that you're working in and the Medicaid program's attitudes and beliefs around these things.
I have a question here from Rachel. Are there templates that can be shared with organizations, such as list of services that will be provided, cost effectiveness analysis, to potentially avoid reinventing the wheel at the local level?
Sure. There is a huge and growing amount of information available from jurisdictions and states that have already gone through this. So in your resources at the end of our presentation, for example, there are a couple of jurisdictions cited specifically, including the Texas credentialing program. That is in there. Thank you. They have a certification program already in place, and I'm not picking on them as, you know, the only one, but they have put a lot of time and effort into building out their program, and it's been in place for many years. But they have lots of materials. There are tons of other resources, articles, think papers, a variety of different things. The public APHA Community Health Worker section has on their website lots and lots of materials. There is also a National Community Health Worker Conference that occurs in the early summer. I tried to find more information out about the 2015 conference, but I haven't seen anything posted yet. But if you type in CHW Quest, that will pull up the materials from the 2014 conference that was held in June in Baltimore. So there are tons and tons of resources out there to help inform your process.
We had Jacqueline from Georgia respond to the slide where you asked questions of the audience, Julia, and she says, yes. Georgia is not an expansion state. It sounds like we'll first need to advocate with the state to ensure that these recommended services are needed and then convince MCO providers to partner with a CBO.
Right, and I assume because there would be only one Jacqueline in Georgia, that would be Jackie Muther, and I have to say, and I don't want to pick on Georgia because they're special in many ways, the Georgia Medicaid program has been really restrictive, as you well know, for many years. And in looking at actually how they've built the program up until now, eligibility is very restrictive, covered benefits are very restrictive. There are some managed care plans in play for the restrictive program that might be very interested, not necessarily around HIV exclusively, because I would assume that each of those programs has a fairly small number of individuals, although they are very likely to be extremely expensive. So I think, and I know that there are folks, and we can certainly talk offline, as this is the Jacqueline and I now, about other strategies that are maybe needing to be undertaken to lay the foundation, and other folks that you know well that can help work to move the dial on Medicaid in Georgia.
And then one last question about asking about giving information on how to become a Medicaid provider. This gentleman, Leroy, says we are a designated certified application counselor agency through our church.
Right. That does not make you a Medicaid provider. So it really, depending on the sorts of services that you're currently or planning to offer, you need to look at the current provider status process and whether or not you would fit that process as it normally stands for Medicaid providers. But I want to point out that in some of these more creative activities, and I'm thinking of a couple of ones, and I'll give you an example. The actual agency that is the CBO that's being contracted with by, for example, Medicaid Managed Care Plan is not a routine Medicaid provider, and there's nothing that generally they're offering in fee-for-service, for example, that would be a covered service. However, one of the managed care plans in that jurisdiction realizes they have hundreds and hundreds of enrollees assigned to them by Medicaid they cannot find. And so they are contracting for outreach workers from an ASO to actually go out and find them. And they're paying for that under their administrative costs. So there's lots of flexibility around this. Now, it is absolutely in the best financial interest of the managed care plan to locate those folks, because under their contracts, if they do not provide a service to somebody, they don't get paid for them. So hiring under contract a couple of community health workers spend all their time out of the office, out of the cubicle, locating folks, linking them to service, getting them engaged in care is absolutely in the best interest, because all it takes, once again, is one inpatient stay, and they would basically be funding a community health worker for the year. Other questions?
I don't think we have any more questions. There are a couple that I have about reaching you offline, and I think that kind of segues us into what's next, unless you had
Sure.
anything else, Julia?
No, I'm done. I just want to thank everyone for their time, and we really appreciate your interest, and good luck.
Thanks, Julia. This is Stephanie again from AIDS United, and we really do appreciate your interest, as Julia said. And we do have a unique opportunity for you. If you are interested in having a small group conversation about this and connecting more offline with Julia, we are taking emails from organizations, so you can email me as soon as you'd like if you're interested, and we'll set up a conference call of sorts with the first 15 organizations that respond to this opportunity. And so that's your chance to pick Julia's brain a little bit more and have some more engaging conversation around this. So that's one thing that's coming up next. And then after you sign off from the webinar, you should see a brief survey. We'd really appreciate your feedback. And then in the next couple of days, this presentation is being recorded and it will be shared with webinar participants. So you can take a look for that or email me for the recording as well. And watch out for future announcements from AIDS United in terms of webinars. And I just want to say thank you again to Julia Hidalgo. Here's Julia's email for those of you who are asking about reaching her offline as well. And if you're interested in any more information about sector transformation, whether it's about the program or grants or technical assistance, you can reach me at the email you see on your screen. So thank you very much, and I'll see you again online soon.